on to the second session, a clinical session. Before I invite the chairpersons, I would like to just a little bit in sequence change because Dr. C.K. Ponde has another meeting. So he has spoken to Dr. Darshan Jhala. So instead of Dr. Darshan Jhala being the first speaker, chairpersons are requested to call Dr. Ponde as first, then Darshan Jhala, then Dr. Jamshed Dalal. So with this introduction, I think I would invite the chairperson, Dr. H.K. Chopra from Mulchand Hospital, Delhi, Dr. P.C. Manoria from Manoria Cardiac Hospital from Bhopal, and Dr. Viveka Kumar from Max Hospital, Delhi. Over to chairpersons.
Thank you very much, Dr. Mahapatra. I think at the outset, I really want to compliment Dr. P.C. Manoria for his beautiful talk and a lucid presentation, a 360-degree panoramic view, and starting the ball rolling. I think it's a very important information he provided. And we have a very important clinical segment now. In the clinical segment, we have 3 speakers. You just heard Dr. Mahapatra, that our first speaker is none other than our own Dr. C.K. Ponde, who will be talking about risk stratification in HFREF. Following him, there will be Dr. Darshan Jhala, who will be talking on biomarkers. And then, of course, Jamshed Dalal on a very important subject, how to optimize and titrate the patients by clinical monitoring or by making a checklist. I think it's very important. We just heard, ladies and gentlemen, before we really start, Dr. Manoria, that the quadruple therapy is a unique, iconic molecules in treatment of heart failure, which is revolutionized. And they are the gold standard. They have changed the whole scenario of armamentarium of heart failure management. Even Dr. Manoria has mentioned that the need of ICD and the need of CRT is postponed. Heart transplant is postponed. And there is a complete reversal of the remodeling or a partial reversal of remodeling. Some are dependent, some are not dependent. It's a very beautiful message. And I think with these few words, I hand over I request Dr. C.K. Ponde to have his presentation. Dr. C.K. Ponde, sir, on risk stratification in HFREF, ESC and ACC guidelines.
Thank you, sir. Thanks, Dr. Chopra, and thank you, Dr. Manoria. Dr. Manoria, your talk was really wonderful. You gave a complete overview about the heart failure with reduced ejection fraction. I'll just share my screen. After that towering talk by Dr. Manoria, let me see whether I can do some justice about how do we move with the guidelines. See, Dr. Manoria already told us that every hospitalization in heart failure is a bad news. And he also told us that the mortality in heart failure is very high. But the lifetime risk of 1 in 5 persons above the age of 40 will develop heart failure in his lifetime. So 20% of the adult population heart failure will develop. So heart failure is going to be a big thing in the next 2 or 3 decades or so. Heart failure is deadlier than many cancers. As you can see here, 5-year mortality of heart failure is 48 to 50% and is higher than leukemia, colonic cancer, and even non-Hodgkin lymphoma. What about Indian patients? In Indian patients, 1 out of 3 patients are readmitted in India within 1 year, and 1/3 of heart failure patients in India die within 1 year during their productive life years, which is very, very sad. The mortality over 3 years in India is approximately 46%, and this equates the 5-year mortality across the globe. So in India, the 3-year mortality is equal to the 5-year mortality of heart failure in the other parts of the world. Guideline-directed medical therapy is proven to reduce mortality and morbidity, but many eligible patients are not receiving one or even more of the recommended medications, often due to suboptimal initiation. Clinical inertia, Dr. Chopra was just talking about. There's a clinical inertia, and Dr. Dalal is going to talk about how to titrate these drugs and how to use these drugs interchangeably or together in patients with heart failure. In India, only 25% of HFREF receive the guideline-directed therapy. In Indian heart failure patients, the Kerala registry has shown us that suboptimal treatment carries higher mortality than the GDMT, and if the patient has multiple readmissions, more than one readmission, carries higher mortality. So more the hospitalizations, more the mortality, less the guideline-directed therapy, higher the mortality. So the ACC 2022 guidelines clearly say that step 1, you establish the diagnosis. Step 2, the moment you detect ejection fraction of less than 40%, you consider the drugs which are the guideline-directed medical therapy for all the 4 fantastic pillars. And if these fantastic pillars, despite this, if the patient remains symptomatic, if it's a Black African American, you can consider isosorbide dinitrate hydrogen combination. Or if the patient remains symptomatic and is not an African American, then you can consider ICD, CRT, and CRTD, depending on whether the QRS is broad and depending on whether the underlying substrate is ischemic versus non-ischemic cardiomyopathy. So I think the guidelines are pretty clear. Unfortunately, the penetration of the guidelines in clinical practice is dismal, pathetic, and sad. I can tell you that in our own hospital, when we did a study between 5 cardiologists, 3 physicians, and 3 intensivists put together, only 30% of our patients left the hospital on more than 2 out of these fantastic 4 at the time of discharge. At 1 month, only 50% patients were adherent to therapy, and at 1 year, only 32% were adherent to therapy. So you can imagine it is a pretty bad news that guideline penetration is pretty bad. So you have chronic HFrEF patients, you have acute hospitalized decompensated patients, you have newly diagnosed de novo heart failure patients, and you have post-surgical or post-PCI heart failure patients. So if you look at the guideline for chronic HFrEF, the first question we always have, should we shift all patients of HFrEF who are on ACE inhibitor to ARNI? Recently, with Dr. Chopra's mammoth and phenomenal efforts, we had a national consensus at Delhi, which involved 50 top physician, cardiologists, nephrologists, and endocrinologists for consensus statement of use of ARNI in heart failure. And this is an eye-opener slide which tells you that there's nothing like stability in heart failure. 20% of stable patients had a primary event and paradigm trial, 17% died during the course of the trial, and 50% of these deaths were sudden. So you should not wait for stability. You should not wait for a refractoriness. You should shift the patient to ARNI as early as possible. And ACC 2022 guidelines clearly say in patients with chronic symptomatic heart failure, class 2 or class 3, who tolerate ACE or ARB, they should be replaced with ARNI. And of course, those patients who remain symptomatic, with class 2 and class 4 symptoms, an MRA, a beta blocker, and an SGLT2 inhibitor are other 3 pillars, fantastic pillars of this guideline-directed therapy. Even the ESC 2021 guidelines clearly say ARNI should be considered as a first-line therapy in place of ACE inhibitor. That means gone are the days where you need to see whether the patient tolerates ACE inhibitor or not. Even if it's ACE naive, newly diagnosed patients with HFrEF, you should upfront start ARNI, because this is the molecule which Dr. Manoria showed us just now, reduces cardiovascular death, reduces new onset of diabetes, reduces insulin requirement, reduces sudden cardiac death in patients with HFrEF. And no other molecule has shown such concordant benefits, even in renal outcomes, in patients with HFrEF earlier. So ARNI is recommended as a first-line therapy by ESC 2021 and ACC 2022 guidelines as well. What about hospitalized patients with heart failure? Remember, hospitalization is the ideal time to consider optimization of therapy and initiation of therapy, because people and patients and their relatives are in a vulnerable state of mind, very receptive state of their mind. So whatever is started in the hospital, they are more likely to adhere to it. They are more likely to follow it. They are more likely to adapt to it. And they are more likely to spend money for those expensive drugs to stay with the guideline-directed medical therapy. Moreover, Pioneer heart failure trial, which was done just in this group of patients with acute decompensated heart failure, randomized between enalapril and sacubitril/valsartan combination, clearly showed that the fall in NT-proBNP at 8 weeks was much better with sacubitril/valsartan as compared to enalapril, and even cardiovascular death and recurrent hospitalizations at 8 weeks was reduced by a phenomenal value of 42% with a p-value of 0.007, the benefit starting as early as 1 week. My friends, 1 week. Within 1 week, you start ripening the fruits. I mean, getting the benefits out of this therapy. And very few therapies in heart failure have separation of Kaplan-Meier curves in the beneficial direction, just the way ARNI has shown. So in HFREF patients, initiation of ARNI during hospitalization is of high economic value compared to delayed initiation post-discharge. So guideline-directed medical therapy should be started during hospitalization after clinical stability is achieved. Meaning what? The patient should be not oxygen dependent. Patient should not be orthopnic. His chest should be clear. He should not be on inotropes, and he should be maintaining saturations on room air. These are the patients with reasonable blood pressure. You can start guideline-directed medical therapy, as many pillars as you can, so that those can be up-titrated every 2 weeks in your OPD visit, depending on blood pressure, volemic status, potassium, and postural drop of blood pressure. So you can really start as many as you can during hospitalization, before discharge, and then keep on up-titrating them. Of course, if side effects occur like prohibitive hyperkalemia, etc., you may land up in down-titrating the dose or omitting an MRA, etc. But that is later. Initially, if potassium permits, you should start even an MRA before discharge. ESC 2021 guidelines again say initiating ARNI in hospitalized HFREF patients before discharge. So, and they also say one step ahead that those admitted with ADHF, oral OMT should be continued except for possible dose reduction or withdrawal if there is a hemodynamic instability or there is a prohibitive hyperkalemia. So recent ACC 2021, ACC 2022 and ESC 2021 guideline clearly recommend GDMT initiation before discharge. What about de novo heart failure patients? Please remember, acute decompensated chronic heart failure and de novo newly diagnosed heart failure are little different animals. When you talk about de novo heart failure, patients are younger, more likely to be women, more likely to be non-ischemic etiology. These patients were often excluded from large heart failure trials. They have lower rates of mortality and readmissions and novel clinical trial opportunities to study implementation of GDMT in this group of patients. Whereas worsening known chronic heart failure patients, these are older, they are more proportions of men, more of ischemic etiology and higher rates of mortality and readmission. And these have been the focus of the known trials that you know, Everest, Galactic, Victoria, which Dr. P.C. Manoria alluded to in his talk just around a few minutes ago. But if you look at the 30-day mortality rates of ADHF versus de novo, they are almost the same. All-cause mortality, however, of de novo heart failure patients climbs steeply in absence of GDMT over 1 year, from 1 year to 10 years. So 10-year all-cause mortality rate approaches 72%. Transition study exactly showed us the treatment of de novo heart failure patients with GDMT initiated in hospital does wonders to the mortality and rehospitalization rates of these patients. So sacubitril/valsartan keeps de novo heart failure patients out of hospital and makes them live longer. It also improves echocardiographic remodeling and causes reversal of remodeling. Left ventricular volumes come down, left ventricular dimensions come down, LA volume comes down, wedge pressures come down. That is a surrogate of E by E prime, and even LA strain values improve in patients with de novo heart failure patients who are treated with ARNI. So sacubitril/valsartan is now recommended for de novo heart failure patients who are ACE or ARB9. That means who have never received ACE or ARB in their lifetime. What about post-PCA or post-CABG? We have a huge population of patients post-PCA and post-CABG LV dysfunction heart failure. And these patients, again, if you treat them with GDMT, you can reduce their mortality. You can reduce their rehospitalization. So it is important that to understand that even if revascularization has occurred, that doesn't mean that these patients should not receive GDMT if their ejection fraction is 35% or 40% or below. So heart failure patients undergoing revascularization represent an important population at risk of death. What is the next step then? The next step is medical therapy is essential, but GDMT should be considered for all patients with complex CAD treated with medical therapy, as we discussed before, PCI or even CABG. And in select patients with heart failure, with reduced EF, who have got recurrent angina with dynamic ST segment changes, reversible myocardial ischemia on thallium perfusion scan, or large amount of resting hibernation with a PET FDG scan, they should be, and if the coronary anatomy is suitable, they should be considered for revascularization. What about sequencing? Forget sequencing. No sequencing. You start them with all the 4 drugs, or let all the 4 drugs be on board as early as possible, at least in 4 weeks, and keep on up titrating them to a maximal tolerable dose. I will not say target dose, but at least maximal tolerable dose. And every effort should be made to achieve and maintain clinical trial defined target dosage. But 2 messages are very important. Even if symptoms improved or other indicators of response were shown at lower dosage, medication still needs to be up titrated. Even if the patient becomes asymptomatic, that is not the reason to keep him at lower dosages. Keep on up titrating, because you get mortality benefit. You get recurrent hospitalization benefit. And if the target dose cannot be achieved because or is not well tolerated, then the highest tolerated dosages should be continued. So to conclude, go with the guidelines, and go with the guidelines. Thank you very much for your attention.
Thank you very much, Dr. Ponde. I think since you are leaving off this meeting, I just like to give a very important clue. What we learned from your talk is early GDMT is the only solution to reduce the morbidity and mortality, whether it's a long term or a short term. It's a very important message.
Yes, sir.
And the second message which you highlighted on EDHF and de novo heart failure, and his third important message is post-MI, post-PCI, post-CABG. I think this is a very, very important message. Safety has been known, but we need to have more data, like in heart, especially after MI, as to how effective it is. But we need to start all these drugs. This is a very, very important message given to us. And de novo heart failure, you mentioned about the young people, the women, and especially those who are non-ischemic. The benefits are enormous. We have a huge consensus coming up with 40 points of consensus. Very shortly, in next 15 days, it will be published in JAPI. I think Dr. Ponde was one of the very important person there. It's a very, very important information. The same thing has been highlighted by Dr. Manoli, that the time has come, we cannot sub-optimize the treatment, and we should not de-escalate the treatment, except 4 entities: inflammatory, COVID cardiomyopathy, and of course with increased epinephrine, norepinephrine stress cardiomyopathy, and in the patient with pericardial cardiomyopathy. That's a very important message. Otherwise, escalation is the only answer. Don't stop the treatment. If you reduce the treatment, mortality is very high. I'm very impressed by Dr. Ponde giving the data of his own hospital, intensivist and a cardiologist, and he has shown very clearly that 30% is the total, I think, drug titration, which is covered by all of them. So we need to educate ourselves. We should not have any inertia. Time has changed. If there are any questions in the audience, one can ask it.
All of us enjoyed the very clear messages from Dr. Ponde. Thank you, Dr. Ponde.
Thank you, sir. I need your blessings, sir. Dr. Chopra, Dr. Manoria, Dr. Mahapatra, I need your blessings, all of you.
Thank you very much.